Having everyone at the table makes the science better. That's why I'm so passionate about making sure that we have the voices of the people who are going to be using our drugs, using our products there from the very beginning and helping design how we do the trials, where we do the trials, who we work with, what the procedures are like, what questions are really important to understand in addition to safety and efficacy.
Listen, we do whatever it takes to make things happen, right? That's why we're here, because we address hard things. This is not easy, the topic that we're talking about today, but the topic that we should be talking about all the time. I'm Carmen Villar. I'm with Gilead Sciences. I'm Vice President for ESG and Corporate Citizenship. I should have started with that, right? Anyway, but I was here last year at the inaugural event of the Health Equity Forum, and this year I have the pleasure of being part of the steering committee, which is why you saw the Gilead advertisement just a second ago. But really, that was our lead, Dr. Das, that was our lead person on the Purpose trials, or the Purpose program, which I am going to be talking about with one of our participants of our Global Community Advisory Group in just a second. But before I do that, I just want to give a little bit of context. And one of the things I want to say is, last year when I was at this forum, I was representing a different company. And very shortly after that, I moved to Gilead Sciences. And one of the first meetings I went to, where we call it State of Gilead, but our CEO stood on the stage to give us the quarterly update of everything that's going on. He started with the two big priorities for the company, which are scientific innovation and health equity. And I almost fell out of my chair. I thought, I'm at a pharma company where they're talking about, the CEO is talking about health equity. And I thought to myself, I made the right decision. Our scientific innovations at Gilead, and don't get me wrong, there's a huge R&D arm. There's lots of pressure from the street to get it right, to get those scientific innovations to the end line. But for the purposes of then creating access to communities most in need of the products that we make, that we innovate for. And that is vital to our success, because we all know if you make something but you can't get it out there and sell it, there is no community service, there is no philanthropy, there is no partnership, which is so key to any of the work that we do. So back to the Purpose program. The Purpose program is the most comprehensive and diverse program for any investigational HIV pre-exposure prophylaxis medication ever conducted. That's a mouthful. We just say PrEP, HIV PrEP. So it's a prevention tool that can prevent you from getting HIV if you are so exposed. Okay. We decided that we needed to talk to people, as you saw in the video, that would be affected, could possibly use this medication. We needed to engage them early and understand what some concerns are, help them understand what we were trying to do, get their feedback, and make it a two-way dialogue to have true community impact. Now, I'm highlighting this program today because we all know that that is what it takes to be successful in our health equity efforts, in addressing the social determinants of health. You can't just put out a marketing program and say, okay, everybody take this drug and everybody's going to take it. No, we know that doesn't work. We have to speak similar languages. We have to really go to where the client is, where the patient is, and understand what else in their daily life they are dealing with, and how we can make it easier for them to get access to healthcare, not through the emergency department, right? And then understand why they might be afraid or hesitant to engage in the discussions, especially around something like HIV, which we know is still very stigmatized, especially in Black and brown communities. Anyway, I'm really off script and I'm going to get in trouble. Jesse's going to get really mad at me in a second. But anyway, today I have the pleasure of having a discussion with Dr. Martez Smith, who's going to join me up on the stage in a second. But first, I want to say that this, and I'm going to say young man because I know I am older than him, but he is amazing. Dr. Smith holds a PhD in nursing and health science from the University of Rochester and is a licensed master social worker. I'm a social worker too, but I am not a master. He is a postdoctoral research fellow at the HIV Center for Clinical and Behavioral Studies at Columbia University and the New York State Psychiatric Institute. You know, there's a whole thing on here about how great he is, but I'm just going to invite Dr. Martez to the stage to join me. Can you hear me? Yeah, okay. So for those of us that don't work in the world of HIV, I'm going to start there just so we can kind of set the ground. And you and I know that statistics around HIV infections are not great, especially for people that look like us. So maybe can you give us a few examples of how these disparities have appeared in the communities where you live and work?
Yeah, definitely. So what I usually like to say about HIV, along with a lot of other ailments that we face in modern society, is that they often tend to follow that gradient of socioeconomic status, right? So you think about socioeconomic status being comprised of different things like race, income, educational attainment, where you actually might live in a city or in a country, in a state, and how those things impact access to resources, equitable access to resources. HIV is no different. And so what we're seeing, I want to say, I think the most recent surveillance report was on 2 years ago from 2022 data. And what we found is even though like COVID was a thing, we still see like Black gay men who have sex with men being the highest impacted by new HIV diagnoses, right? Followed by Hispanics, followed by Black women, right? And so that's one of the things that we're seeing. We're seeing in the South, right, extreme disparities, right, in terms of who can actually get somewhere to get tested, right? If you can't get anywhere to get tested, right, you don't know what options are available to you, right? We're seeing a lot of stigma, right? Even though we have all these amazing advances, long-acting injectables for pre-exposure prophylaxis or for PrEP, we have long-acting injectables for treatment now. We know more than we've ever known about sexual health and HIV, yet and still we are facing these outlandish disparities.
Yeah, yeah. Sexual health. Why are people so afraid to talk about it?
I don't know. I mean, it's how we got here, right? So,
right, right. Each one of us.
Yeah. I mean, hey, I feel like we could solve a lot with just adding comprehensive, sexual health education in schools, but different topic for a different day.
I know there's somebody here that's going to talk about wellness in schools later, so maybe she can help us out. Anyway, not sexual health, but it's okay. It's okay. In the Purpose program, and I just want to clarify that we had a global community advisory groups, even though Dr. Smith is from the States, he was part of a broader group and really talking about these kinds of issues, but with very similar issues in other countries across the world. The stigmatized nature of the disease, but also SES, socioeconomic status, affecting a lot of the impact and social determinants of health. But today, the community leaders remain crucial members of the Purpose team. Some of the GCAG members started maybe 4 or 5 years ago, have been involved with us through this entire journey. Thank you, by the way. But can you discuss how the GCAG incorporated the perspectives of advocates for diverse communities into the process?
Oh yeah, this is actually one of my favorite things to speak about. So we did a lot, and looking back, I mean, now hearing you like articulate it back, and then with the Purpose 2 results being recently released, it's like, oh wow, we really did a lot. So first and foremost, one of the really awesome things that Gilead did with us is that they invited us to the table early on, right? Not quite at the inception of the study, but I think by the time we were there, I think the clinical trial sites where the study would be going on were already selected. And we kind of came in, and of course, we kind of yelled at them about that. Like, you need to engage us before you select
Nobody's
sites.
perfect.
Right. But more on that later. And then we were like, okay, well, since you've already picked the sites, what we can at least do is give you some advice and some insights on how you can actually make the study itself equitable, rooted in a health equity framework. And so what we did is we said, if we know that HIV impacts XYZ XYZ populations at these rates, then that's how you need to construct your study sample. So I think, if I'm not mistaken, the set-asides were, I think, 50% were, I think, trans and non-binary. I think 25% were cis men, and I think another 25% were women of color, cis women of color, if I'm not mistaken. I think. Don't quote me exactly. I can get the papers for you later. But so yeah, but we pretty much told.
You helped to write those papers, by the way.
Yeah. That's the thing. We wrote them a while ago. It was a protocol paper. So, but yeah, so we pretty much told Gilead, we're like, look, if we know globally this is what the HIV epidemic looks like, then we need to make sure that those people are being included in these studies. And by doing that, we're able to open up a lot of different other pathways that not only help get folks into these studies, but open pathways up for healthcare in general for them. Because, right, these study sites are oftentimes clinics or clinics within hospitals or large FQHCs with research wings. So, yeah.
Yeah. No, thank you for that. And I just can't tell you how inspired I am by this story. I wasn't even at the company for when this all started, but it is such an amazing story to bring back practical experiences to this group instead of just talking at policy levels and sort of high levels. And that was my challenge last year, to be honest, was how do I actually help people understand how to do this work, which I think a lot of you know already, but hopefully other people who don't are learning something today. Anyway, we talk a lot in our industry about patient centricity or patient-centered design. And I'm not going to explain what that means. I'm going to ask you to tell us a little bit about what that means to you in your work and how that was carried through in the Purpose program.
So for me, when I hear patient-centered design, I mean, I think a lot about, I don't know if we have a lot of business folks in here, human-centered design. So when you have a product, it doesn't matter what type of product it is, when you are designing that product and figuring out how to market that product, you're keeping your audience in mind, your target audience in mind. So this includes, right, HIV drugs, right, or a research study in this case. So I think of the study as like the product that you're trying to sell, right? So earlier I mentioned something about pathways, right? One of the things that we made sure to do is that when sites reported that they were like struggling to recruit either a certain demographic of participants or just recruit women in general, we would go through an inventory, like a checklist with them and say, okay, well, what policies, procedures, and programs do you have in place to remove, things like transportation barriers, right? Certain organizations, where it would help certain organizations get like ride-sharing programs started up. Some organizations would just pay for a cab or a Lyft, right, just to make sure that there was no transportation barrier. Some sites went above and beyond, right, and they had like daycares, right, or they would coordinate daycare for folks with children who wanted to participate in the study. So just those are two things off the top of my head that I can think of, right, that the sites did that was informed by the community advisory group. Another thing that we also we did incorporate were exit interviews. So there was always a qualitative portion where we interview participants, a subset of participants, about their experiences in the study and about their thoughts overall about the drug. And if there are any specific things that we can do at the site level or that we can do at the community level to remove those barriers. Oh, and this is a really cool thing too. So as a GCAG member, as a local GCAG member, I was invited to attend local site visits whenever a Gilead member would be in town. And in that same vein, it kind of made me an ambassador of the study. So I was able to actually like get some folks that I knew and referred to the study because they were like, hey, I know that guy and I know what he's about, so I trust him. I might not trust Gilead, but I trust him. So, But I mean, I think that kind of proves the point, right? We're removing the concentration of resources from the top, right, and kind of spreading it across, right?
Yeah, that actually is not on my card, but I'm gonna relationships are so important, right? And what is on my card is talking about the impact of partnership. But I think what we forget sometimes is that doesn't just come overnight. That a lot of these relationships are built over time because you have to create trust between you and another individual. And especially in a business where we are so pressured for quarterly results and, all these things, that can be sometimes lost or forgotten. And so maybe talk a little bit about the partnership with community and what that means for this kind of a study and to you and your work.
Yeah, definitely. So I'll just start like from the beginning. I mean, this was a process, right? This was something that was definitely trial and error. I can remember sitting on some of the previous Gilead community advisory groups, and the way that things were done were not optimal. I'll
That's
say that.
okay. Bring it. Come on.
But what I will say, and what I will commend Gilead for, and a lot of other organizations or institutions are falling in line with this, is actually listening, right? So, like, how can you have a successful relationship, be it romantic, whatever, if you're not listening to the person who you're in the relationship with, right? And actually taking the feedback and making said changes. And so I will say, just Gilead being willing to listen and change their practices really is what got us here today. Because if they weren't listening, we wouldn't be having this conversation. But yeah, it was really the fact that Gilead was able to listen. So I think I was in a separate community advisory group before Purpose 1 and Purpose 2. And they just kind of like threw us all in the room together. And like early on, we said, okay, moving forward, you need to invite us from the inception, right? Like, don't wait until you have a study protocol all drafted, you've picked all of your sites out, you talk to the FDA, you talk to the IRBs. No, like, we want and need to be involved from the inception, because as people living with HIV, as people who are impacted by it every day and who have to take these products, if you want me to participate in your study or if you want me to take your drug, I need to know and feel that I can trust in you, right? And so some of the ways that I feel like Gilead was able to do that is by having people like myself, my colleagues on the ground to attest to that. So.
Yeah. Were there any other key takeaways for you from this experience that you might, give us a hard time about, or I mean, highlights that you might want to share with people in this room that you would consider best practices?
Yeah, so listen to your community advisory groups, right? Don't just have them for like face value, which I've found oftentimes happens, or just because there's like regulatory things, or like, oh, we need to include community voices because it looks good, or there's this policy that says we have to do so. No, like your community constituents, your constituents on the ground, your lay folks, they have a lot more power than you think to really make or break your efforts, right? So if at the top or on paper you look great, but in the community, your reputation, excuse my French, is shit. I mean, if you can't go into a room, right, as a representative of your own organization and not get tomatoes thrown at you, then you're probably doing something wrong on behalf of your community. So one of the things I can say is that over the 5 or 6 years that I've been partnering with Gilead, is I've really seen them put their money where their mouth is. I've really seen them diversify their staff, diversify the community advisory groups, diversifying the studies, right? And I think I know it's had a real live impact. I mean, so even with the rollout, right? So kind of making sure that not only that Gilead is doing things at the top and from a clinical research perspective, right, but on the ground, my nonprofit organization has actually received some funding, grant funding from Gilead to make sure that communities have the resources they need to prevent and treat HIV accordingly. So, just thinking about really nifty measures like that, where you can kind of Oh yeah, and then coalition building too. That's another thing. Coalition building is super important, and I think with the community advisory group, with us coming from so many different regions and us working in different industries, if you will, but all kind of having this one thing in common, that being HIV prevention and treatment, we were able to exchange resources. So, I keep thinking of things. I'm sorry.
No, that's why you're here.
Yeah, and then I think the thing that I really loved about it, that I really feel like just kind of drove home the equity component of this, was the fact that Gilead was very proactive about including community members on their abstracts and their manuscripts. And so if you look up some of the Purpose 2 studies, you'll see my name on some of those abstracts and manuscripts because I was invited to co-author them. And when you talk about building a workforce to make sure that we see an end to this, that's one of the ways that you do that.
Yeah. Now, you mentioned that some of those were early on. Can you just describe what a few of those papers are? And then maybe especially for those folks that don't work in the HIV world, maybe just, if you don't feel comfortable, I can do it, but talk about what some of the purpose results, what we just heard, just to remind folks and level set.
Correct me if I'm wrong, because I have like so many different acronyms floating around here. So if I'm not mistaken, the Purpose 1 and 2 studies were for long-acting injectable PrEP, right? Lenacapavir.
Yeah. And that means twice yearly you get an injection for the prevention of HIV. Okay.
Yeah, and in the studies, if I'm not mistaken, they found that it's non-inferior, so it's equally, if not more effective than daily oral PrEP, which is that's the method of choice now, pretty much.
Yeah.
Just a pill that you take every day. But this is once every 6 month injectable shot. Yeah. Before Purpose 1 and Purpose 2, we did the Brave study, and man, that was like back in 2020. But the study was all African American, and I cannot remember exactly what it was about. I'm so sorry, I'm
That's
forgetting.
okay.
But
That's okay.
so yeah, there's that abstract, and then there was I want to say it was a community recruitment, like a community engagement protocol paper that we wrote for the Purpose 1 and Purpose 2 studies that actually detailed, how the community advisory group was convened, what our internal processes were, like how we set rules for ourselves, the actual suggestions that we made to Gilead scientists about the studies. So,
Yeah. No, that's really helpful. And I focus on that scientific piece and the abstract writing because a lot of the work that happens is at the community level. I think what we fail to do sometimes, though, is to help people realize what it takes to get those things published, to get their voices out there in a world where they may not be used to communicating. And I think that process, I used to work in the government, and we did a lot of that work through grant making and working with scholars and in the academic system. But I think this coming from a community level and really helping people understand what it means not only to be involved, but then to be a part of how we share the information and communicate that is really critical. So thank you so much for sharing that. I think what I just want to also be clear on is that this product is not yet registered with the FDA. Our company will be doing that by the end of this year, and then hopefully we'll get regulatory approval next year. But this is actually creating an opportunity for us to really have an AIDS-free generation, which is something that we've been striving for a long time, but we actually potentially, with this tool and the many other tools in the toolbox from other companies, we may actually be able to do this, not just in the U.S., but globally. And this is what is very exciting for us. So I just want to say thank you, Martez, for being that community voice, for showing up here today to share this story with us and with everybody in the room, and for keeping on and doing the good work that you do every day. So thanks to
My
Martez.
pleasure.
Thanks to you all. Appreciate it. All right.